Welcome back to the deep dive. Okay, picture this. You're in the ED, it's busy, and a patient comes in, heart just racing, tachycardia. It happens all the time, right?
Constantly.
And you've got to make decisions fast, really fast.
Seconds count.
Okay, let's unpack this. The rapid-fire world of narrow, complex tachycardias in the emergency department.
Yeah, and what's really key here, I think, is how often you see these rhythms. Knowing those subtle differences, that one little clue on the ECG can make a huge difference. It's not just theory, it's about acting quickly and correctly.
Absolutely. So this deep dive, it's actually based on a listener request,
Yeah.
focusing right in on those narrow, complex tachycardias you really need to master in the ED.
Exactly. Sinus tach, flutter, AFib, MA, PSVT, the ones you'll definitely encounter.
Our mission today is to cut through the complexity, give you those essential takeaways from the latest guidelines, the core texts, and make sure you feel confident handling these. What to look for, what to do, and maybe even more important.
What not to do. There are definitely some pitfalls.
All right, so patient comes in, heart's racing. Before you even glance too hard at the monitor, what's the absolute first question, the immediate priority?
Stability. Always stability first. Forget the specific rhythm for a second. Are there adverse features? Is the patient crashing?
Okay, and what qualifies as an adverse feature? What are those big red flags?
Well, you're looking for signs the heart isn't pumping effectively. So hypotension is key systolic below 90, then signs of shock. Pallor, sweating, cold skin, confusion, altered mental status.
Okay.
Syncope obviously is a big one. Any signs of heart failure, pulmonary edema, raised JVP, peripheral edema, maybe hepatomegaly.
Right, the fluid overload picture.
Yeah. And finally, myocardial ischemia. So new ischemic chest pain or, ischemic changes popping up on the ECG if you see any of those.
And it doesn't matter what the narrow complex rhythm is, the first step is universal.
Electricity. Synchronized DC cardioversion. That's the highest priority. Treat the patient, not the monitor.
And the energy levels.
For narrow complex tachycardia or atrial flutter, you usually start around 70 to 120 joules. You can increase incrementally if the first shock doesn't work, up to 3 tries.
Okay.
For AFib, though, atrial fibrillation, you generally start higher, often at the maximal defibrillator output recommended by the manufacturer.
And if cardioversion doesn't work after 3 attempts and they're still unstable?
That's when you'd consider amiodarone, 300 milligrams IV over 10 to 20 minutes. Then you can try cardioversion again. But the key is unstable equals shock first.
Got it. Treat the patient.
Yeah.
Okay, so let's say the patient is stable, or you've stabilized them. Now we can dive into the ECG. We're focusing on narrow complex tachycardias QRS less than 0.12 seconds.
Exactly. Normal ventricular conduction time. This bucket holds several common rhythms.
Let's start with maybe the most common, but one that can trip us up.
Ah.
Sinus tachycardia. What makes it definitively sinus tach on the ECG?
It looks like a normal rhythm, just fast over 100 beats per minute. The absolute key is seeing normal sinus P waves. They look the same, they're upright in the right leads, and there's one P wave right before every single QRS complex. Normal PR interval, 1-to-1 conduction.
Even if the rate is, say, 140, 150.
Yes, though remember that rule of thumb, 220 minus the patient's age for max heart rate. If it's way above that, you should be suspicious. It's not just sinus tach. But the morphology of the P wave is crucial.
And the management principle here is fundamentally different. Right?
Totally different. Sinus tachycardia is almost always a response to something else. It's the body compensating.
Like what? What are the common culprits we should be hunting for?
Oh, loads of things. Pain, anxiety, fever, hypovolemia, dehydration, bleeding. Sepsis is a huge one. Hyperthyroidism, PE, even MI.
So the management isn't about slowing the heart rate directly.
No, absolutely not. You do not use cardioversion or antiarrhythmics for sinus tach. Your job is detective work. Find the underlying cause and treat that. You cannot discharge someone with unexplained persistent sinus tachycardia. Find the why.
Right, crucial point. Okay, let's move to the rhythms that are the primary problem. PSVT, paroxysmal supraventricular tachycardia. What's going on electrically there?
So PSVT usually means a reentry circuit. The electrical signal gets stuck in a loop. 2 main types you'll see.
Okay.
The most common is AV nodal reentrant tachycardia, AVNRT. Here, the loop is actually within the AV node itself, using fast and slow pathways.
And the ECG clue for AVNRT?
Narrow complex QRS, regular rhythm, and often the P waves are buried inside the QRS so you can't see them. Or sometimes you might see a little blip right at the end of the QRS, a pseudo-R prime or pseudo-S wave. That's sort of the classic SVT look, fast, narrow, no obvious P waves.
And the second type?
That's atrioventricular reentrant tachycardia, AVRT. This involves an accessory pathway and extra electrical connection outside the AV node, like the bundle of Kent in Wolff-Parkinson-White syndrome, WPW.
Ah, WPW. So what does that look like on the ECG?
Well, when the patient is not in tachycardia, just in sinus rhythm, you might see the classic signs. A short PR interval, less than 120 milliseconds, and that characteristic slurred upstroke of the QRS, the delta wave. The QRS itself might look a bit wide because of that delta wave.
And when they're on in tachycardia with WPW?
It can be orthodromic AVRT, which is actually the more common type. The impulse goes down the normal AV node and back up the accessory pathway. That looks like a typical narrow complex SVT, though you might see inverted P waves after the QRS. But there's also antidromic AVRT, where the impulse goes down the accessory pathway first. That causes a wide complex tachycardia because the ventricles are activated abnormally, and it can look scarily similar to VTach. P waves are usually hidden.
Okay, so we've identified a stable patient with likely AV-NRT or orthodromic AVRT and narrow complex reentry SVT. What's the first step?
Vagal maneuvers. Always try those first in a stable patient.
Any specific technique recommended?
The modified Valsalva is the go-to now. Get the patient to blow hard into a 10 or 20 milliliter syringe, trying to move the plunger, for about 15 seconds. Then immediately lay them flat and raise their legs for another 15 seconds.
And the physiology behind that?
It increases vagal tone, causing that parasympathetic reflex bradycardia during the release phase, phase 4. It works surprisingly often.
And if vagal maneuvers don't break it?
Adenosine, that's your next step.
Dosing. And how do you give it?
It needs to be given very fast, rapid IV push into a big vein, like the AC fossa, followed immediately by a fast saline flush. Start with 6 milligrams. If that doesn't work within a minute or two, give 12 milligrams, and if that fails, you can go up to 18 milligrams.
Okay. And you absolutely have to warn the patient.
Oh, definitely. Tell them they'll feel pretty rotten for a few seconds, maybe flushed, short of breath, dizzy, chest tightness, a sense of impending doom even. But reassure them it's very short-lived, usually just 10-20 seconds. It helps manage their anxiety.
Important tip. Are there times you shouldn't use adenosine?
Yes. Contraindications include second or third degree heart block or sick sinus syndrome unless they have a pacemaker. And a special note, patients with heart transplants are super sensitive. Give them a smaller starting dose, like 3 milligrams. Also, be cautious in severe asthma or bronchospasm.
What if adenosine doesn't work or it's contraindicated?
Then you can move to IV calcium channel blockers like verapamil, usually 2.5 to 5 milligram IV slow push over 2 minutes, or IV beta blockers like metoprolol, given in small boluses, say 2.5 milligrams up to maybe 15 milligrams total.
Any caveats with those?
Yeah, verapamil is contraindicated in heart block or significant heart failure, impaired LV function. And crucially, don't give IV verapamil if the patient is already taking oral beta blockers or vice versa, risk of profound bradycardia or heart block.
Good point. Okay, shifting gears to atrial flutter. What's the hallmark look of that one?
The classic sawtooth pattern. It's a very regular, organized atrial activity, usually best seen in leads 2, 3, ABF, and sometimes V1. The atrial rate is typically very fast, often right around 300 beats per minute.
And the ventricular rate?
Well, the AV node usually can't keep up with 300, so very commonly you see a fixed 2-to-1 block. Atrial rate 300, ventricular rate 150. The ventricular rate of 150 is a huge clue for atrial flutter.
That's a great clinical pearl. Rate of 150, think flutter.
Exactly. But it can also have variable blocks, so the ventricular rhythm might be irregular, which can make it look like atrial fibrillation sometimes.
So if you're unsure, maybe it looks irregular like AFib, but you suspect flutter.
Adenosine can be your friend. Diagnostically, it'll briefly block the AV node, slow the ventricular response right down, and unmask those underlying sawtooth flutter waves beautifully.
Nice trick. How do we manage stable atrial flutter?
It's actually pretty similar to managing atrial fibrillation. Rate control is often the first step. Beta blockers or calcium channel blockers like diltiazem or verapamil work well. Amiodarone is another option.
What about trying to convert them back to sinus rhythm?
Chemical cardioversion is possible, usually with class 3 drugs like ibutylide or amiodarone. But here's a major pitfall with flutter. Avoid class I drugs like flecainide or propafenone if you haven't already weight controlled them.
Why is that?
Because those drugs can slow the atrial flutter rate down maybe from 300 to 220. If the AV node can suddenly conduct 1-to-1 at that slower atrial rate, the ventricular rate can paradoxically increase dramatically, potentially to over 200 BPM, which is very dangerous.
Wow, okay, that's critical to remember. Avoid class I unless rate is controlled. What about stroke risk and flutter?
The stroke risk is considered essentially the same as an atrial fibrillation. So if the flutter has been going on for more than 48 hours, or you don't know how long, you need to think about anticoagulation using the same risk scores, like CHA 2DS2 VASX, just as you would for AFib.
Got it. Let's briefly touch on multifocal atrial tachycardia, MAT. What defines that?
MAT is characterized by its irregularity and, critically, by varying P wave shapes. The heart rate is usually 100 to 150, sometimes faster. The rhythm is irregularly irregular. And the key diagnostic feature is seeing at least 3 different P-wave morphologies in the same ECG lead. You also see varying PR intervals and varying RR intervals. No sawtooth waves.
And is there a typical patient profile for MAT?
Yes, it's very strongly associated with severe underlying pulmonary disease like COPD exacerbations, pulmonary embolism, or pneumonia. So if you see MAT, definitely think about the lungs. Management focuses on treating the underlying lung issue.
Okay, good clinical link. Now let's tackle the big one. Atrial fibrillation, AFib. We see it constantly. Why is it such a major concern?
Well, AFib is the most common sustained arrhythmia we encounter. It's defined by that chaotic, disorganized electrical activity in the atria, so they don't contract effectively, they just quiver. This leads to an irregular ventricular response.
What are the consequences?
Big ones. It's a major risk factor for stroke because blood can pool in the non-contracting atrial appendage and form clots. It can also cause or worsen heart failure, and it's associated with increased mortality. Plus, the symptoms, palpitations, fatigue, shortness of breath can really impact quality of life.
You mentioned different types, paroxysmal, persistent, permanent. Can you quickly recap those?
Sure, paroxysmal AF means episodes that start and stop on their own, usually lasting less than 7 days, often less than 48 hours. Persistent AF lasts longer than 7 days or requires cardioversion to stop it. Permanent AF is when you and the patient have decided to stop trying to restore sinus rhythm, essentially accepting the AFib and focusing purely on rate control and stroke prevention.
Understanding the type helps guide treatment, especially that 48-hour mark for cardioversion safety.
Exactly. It's crucial for deciding between rate and rhythm control strategies initially.
What's actually causing that chaotic activity, and what underlying conditions should we look for?
Pathophysiologically, it's usually triggered by rapid firing from foci, often in the pulmonary veins, which then sets off multiple re-entrant wavelets in abnormal atrial tissue. Things like hypertension, coronary artery disease, valvular disease, and heart failure are common structural causes.
And the non-structural triggers.
Think about that pirate's mnemonic: pulmonary embolism, ischemia infarction, respiratory disease like COPD or pneumonia, atrial enlargement or maybe a myxoma. Thyroid disease, always check a TSH. Ethanol, the holiday heart syndrome after binge drinking, and sepsis or sleep apnea.
That's a great mnemonic. And you mentioned a key point earlier about treating the trigger first.
Yes, absolutely critical. If AFib is clearly secondary to something acute like sepsis or PE, treating the AFib directly with aggressive rate control or cardioversion before addressing the trigger can actually lead to worse outcomes. Treat the underlying cause first and foremost.
How do we confirm AFib in the ED?
Clinically, suspect it with any irregular pulse. Patients might have symptoms or they might be asymptomatic. The definitive diagnosis is the ECG.
And what are we looking for on the ECG?
The classic triad. 1, no discernible regular P waves. Instead, you see a chaotic or fibrillating baseline. 2, an irregular ventricular rhythm. The RR intervals vary randomly. 3, usually a narrow QRS complex unless there's an underlying bundle branch, block, or aberrant conduction.
And sometimes it can look deceptively regular if the rate is very fast.
Exactly. At very high rates, the irregularity might be subtle. That's where a longer rhythm strip, maybe 30 seconds, can be really helpful to see the underlying irregularity clearly. Also, always consider mimics like flutter with variable block or MA.
Okay, diagnosed AFib in a stable patient. Now what? Rate versus rhythm control is the classic dilemma. How do we approach that in the ED?
The very first question, again, is onset time. If it's clearly less than 48 hours, you have the option of either rate control or rhythm control cardioversion. If it's been longer than 48 hours, or if you simply don't know the onset time, the standard approach is rate control first.
Why the 48-hour cutoff?
Stroke risk. The concern is that a clot might have formed in the left atrial appendage after 48 hours of AFib. Cardioverting them back to sinus rhythm could dislodge that clot and cause a stroke. So for AFib 48 hours or unknown duration, you generally need anticoagulation for at least 3 weeks before attempting cardioversion or a transesophageal echo, TEE, to rule out clot immediately before.
Makes sense. So, for rate control, what are the preferred agents?
First line are usually beta blockers like IV metoprolol or non-dihydropyridine calcium channel blockers like IV diltiazem. Verapamil is another option, but may be used less often due to more negative inotropic effects.
What about digoxin?
Digoxin is generally considered a second or third line option, mainly for patients who are sedentary or have heart failure, where beta blockers or CCBs might be less ideal. It's slow to act and not great at controlling the rate during exercise or stress.
Okay. And if we do opt to rhythm control, say for new onset AFib 48 hours.
You have two main options: pharmacological or electrical cardioversion. For pharmacological, the choice depends on heart structure. If there's no structural or ischemic heart disease, flecainide or propafenone, class ICE, are often used. If there is structural heart disease, 4-amiodarone is generally preferred, class 3. Ibutylide, class 3, is another PHI option.
And electrical cardioversion.
Also a great option for new onset AFib 48 hours, often more effective than drugs. If the AFib is 48 hours, electrical cardioversion is generally preferred over drugs after appropriate anticoagulation, as we discussed.
Now, the huge issue with AFib stroke prevention. How do we assess risk and manage it?
This is paramount. You must calculate the stroke risk using the CHA2-DS2-VASC score for every patient with AFib.
Can you quickly remind us of the components?
Sure. C is congestive heart failure, LV dysfunction. H is hypertension. A2 is age 75 or older. That's 2 points. D is diabetes. S2 is prior stroke or TIA. That's 2 points. V is vascular disease, like prior MI, PAD, aortic plaque. A is age 65-74, and S is sex category. Female gets a point, though its weighting is debated.
And what score triggers anticoagulation?
Generally, a score of 2 or more means anticoagulation is recommended. For men with a score of 1, it should be considered. For women, a score of 1 based on sex alone doesn't usually warrant anticoagulation, but a score of 2, sex plus 1 other factor does. You always have to weigh this against the bleeding risk.
How do we assess bleeding risk?
The Orbit score is currently recommended as being more accurate than older scores like Hasbled, though Hasbled is still widely known.
And the anticoagulants themselves.
The direct oral anticoagulants, or DOACs, apixaban, rivaroxaban, dabigatran, edoxaban, are generally preferred over warfarin for most patients because they're easier to manage and have lower rates of intracranial hemorrhage. Warfarin is still needed for some patients, like those with mechanical heart valves or severe kidney disease.
What about aspirin?
Big point here. Aspirin monotherapy is not recommended for stroke prevention in AFib. The evidence shows the risks generally outweigh any minimal benefit. It's anticoagulation or nothing, based on the CHO2-DS2-VASC score.
Okay, that's clear. Now let's talk about a really critical, potentially lethal combination. Atrial fibrillation happening in a patient who also has Wolff-Parkinson-White syndrome, WPW. Why is this scenario so dangerous?
This is the nightmare scenario you absolutely have to recognize and avoid mismanaging. In regular AFib, the AV node acts as a bottleneck, limiting how many chaotic impulses get through to the ventricles. But in WPW, you have that accessory pathway, an electrical shortcut that bypasses the AV node.
Right.
So during AFib, that accessory pathway can conduct the chaotic atrial impulses extremely rapidly, sometimes one-to-one, directly to the ventricles. This can result in ventricular rates exceeding 250, even 300 beats per minute.
And that leads to?
Ventricular fibrillation and cardiac arrest. It's that dangerous. The ECG will look like an irregular, wide, complex tachycardia, often very fast.
So what is the absolute unbreakable rule for managing suspected AFib and WPW?
Never, ever give AV nodal blocking drugs. That means no adenosine, no beta blockers, no calcium channel blockers like verapamil or diltiazem, no digoxin, and controversially, even amiodarone should probably be avoided acutely as it has some AV nodal blocking effects.
Why? What happens if you give them?
Because blocking the normal AV node forces all the electrical traffic down that fast accessory pathway, potentially accelerating the ventricular rate and precipitating VFib, you're essentially closing the slow road and forcing everything onto the highway.
So what do you do?
If the patient is unstable, immediate electrical cardioversion is the answer. If they are somehow stable, which is less common, the drugs of choice would be agents that slow conduction over the accessory pathway, like IV procainamide or ibutylide. Flucainide could also be considered if available IV, but honestly, most of these will be unstable and need electricity.
That is such a critical takeaway. AFib plus WPW equals AV node blockers.
Think electricity or specific antiarrhythmics like procainamide.
Memorize it. It could save a life.
Wow. Okay. We've covered a huge amount of ground there. From recognizing the subtle signs of sinus attach as a symptom, to the sawtooth of flutter, the chaos of AFib, and that incredibly important WPW pitfall.
Hmm.
Understanding these narrow, complex tachycardias, knowing the pathways, the treatments, it's vital. It really is. It comes down to that careful ECG look, assessing stability quickly, and knowing your algorithms when to use vagals, when to push adenosine, when to reach for the paddles, and critically, when not to give certain drugs.
So for you listening, the emergency physician or clinician managing these patients day in, day out, what's the final thought here?
Well, it makes you think, doesn't it? We're seeing more complex patients, more devices, more tricky arrhythmias. It raises this question. As things like AI for ECG interpretation get better, and maybe we get more real-time hemodynamic data, how is that going to change our immediate approach right there at the bedside? Could we get even faster, even more precise in diagnosing and treating these tachycardias in the future?
That's a fascinating question to consider as technology continues to evolve alongside our clinical skills. A great point to ponder. Thank you for joining us for this deep dive.